Hello viewers, I am Pratik Bhatt from Bharat Serums and Vaccines, and today I welcome you all for the episode number 36 of ART Master Class Season 1. Today we have with us Dr. Sunil Jindal, continuing from our previous lecture talking about male infertility, the medical intervention. So introducing Dr. Sunil Jindal, uh, he is currently MS, DNB, MNAMS, FIAGES, IAGE, and Chief Consultant Laparoscopic Surgeon and Andrologist and Reproductive Medicine Specialist of Jindal Hospital. He is the Scientific Director for Dr. Madhu Jindal Memorial Test Tube Baby Center, Meerut. He is the Vice Chairperson, Delhi ISAR and Delhi IH. Highly decorated with lot of awards and special interest in male infertility. He has major publications and presentations in major textbooks of infertility and over 200 national and international presentations. So with this very brief introduction, I would request Dr. Sunil Jindal to take over the session, and special request to my audience to type any questions in the chat box for Dr. Sunil Jindal. Over to you, Dr. Jindal.
Thank you very much. Thank you very much for the kind introduction, Pratik. And I had been wanting to get in contact and really have a conversation with all of us about the medical management of male infertility. And the reason for this is that male infertility contributes 50%, we all know. Diagnostic investigations in the last lecture I had covered. And something which everybody can do is medical management. In fact, medical management is not only possible for an ART specialist, medical management is even possible for anybody as a gynecologist who gets a patient of infertility and has a male and looks after the male and wants to look after the male partner and treat them. So I have tried to make up my presentation which encompasses everything, different aspects. I've tried to divide them into different aspects. And I've also wanted to bring you and give a touch of the future, the way the future of this science is going to be. So I would begin my presentation. And so male infertility for a gynecologist is so the goal of specific medical management in infertility is to diagnose any reversible causes of infertility and treat them with appropriate medication to achieve ultimately a pregnancy, apart from the seminal improvement. And something interesting is that there have been so many advancements, but still about 25% of men, despite doing everything with modern science has, there is no etiology which can be identified. And because of this reason, there is also something in the ART sector. Now, it's a very, very interesting thing that a lot of people say that today there is ICSI, even if I get one sperm, why do I have to bother about male fertility? So the reason for it is that the overall male health, if it is bad, if the seminal count is bad, it indicates a decreased life expectancy and a lower quality of life. It is so important. And the reduced fecundability, which means the time to pregnancy, and recurrent pregnancy losses can take place. And there is also a negative outcome on ART outcomes, which means if there is a person who has seminal problems or male fertility problems, he is not as good in the outcomes of an IUI, IVF, or ICSI. And apart from that, all the men who have a lower sperm count, the chances of them having a genetic defect which could be transmitted to the resulting offspring is higher. So these are a few aspects for those dealing with ART who need to understand that this is something which needs to be kept in mind. Now, what are the learning objectives? Our learning objectives would be to overview an overview of male infertility conditions which can be subjected to specific medical treatment, And there are a few conventional specific medical treatment. There are some novel specific medical treatments. And because it will be too long, I will not cover the lifestyle modifications, which though form a very major part of the whole male fertility treatment story. Now, sperm output. This is a very interesting slide. So, if you look at it, you would realize that a chimpanzee is 100 pounds. His testicles are 64 cc, and you look at his sperm count. For the humans, it's about 180 pounds, and the size is 20 cc, and you look at the sperm count. And for a gorilla, it's 600 pounds, and the testis is only 14 cc, and look at the sperm count. So, the bigger the man, the smaller would be the testicles, and smaller would be the seminal count. Well, that's the way you could look at it. But when we go to our brothers, chimpanzee and gorillas, we understand that the with the increase in size, the testicle size is becoming smaller. Now, 50% we of course know is contributed by the man. And apart from the physical examination, the semen analysis, special tests, we need to decide whether we need to take this patient for a surgical treatment, we need to take him for medical treatment, or we need ART, or these three need to be combined together, which I will talk about, to give a proper treatment to these patients. So, what would be the conventional treatments? The conventional treatment would be for subclinical male genital tract infection, for endocrine disorders, for ejaculatory disorders, and the novel treatment would be for excessive oxidative stress and obesity related male infertility. So, I have tried to divide them in this fashion and would like to bring these things to you in the same fashion. So, there could be subclinical GTI, genital tract infection. So, if we look at the subclinical male genital infections, the prevalence is about 10 to 20%, and it affects the epididymis, prostate, seminal vesicle, the male accessory glands, and it's a significant cause of idiopathic male infertility. Now, let's understand what happens. So, there is a man who has urinary infection, and he takes antibiotics for 2 days, doesn't take antibiotics further on. This infection, the burning goes away, but the infection stays, and the infection goes into the male accessory glands, which means into the epididymis, prostate, seminal vesicles. Now, the problem is once it gets into these glands, its removal becomes very difficult because the blood testis barrier or the blood seminal barrier does not allow antibiotics to enter comfortably into this region. And once the infection has settled into the male accessory glands, taking it out becomes a big problem. The most commonly affecting organisms are E. coli, could be Pseudomonas, could be gonococcus, can be bacteria, and a culture will tell you. In gonorrhea, a culture could tell you, or you could use a NAT for that. Chlamydia, you could detect by culture and NAT. Ureaplasma by culture or NAT. Mycoplasma hominis by culture or NAT. Now let's understand one specific thing, that for all these um, bacteria, the antibiotics which penetrate need to be given for a longer time, or what time they need to be given for. It is dependent on the examination. So the male needs to be examined. It is not that the semen needs to be examined for pus cells. The male needs to be examined. And depending on the examination, the duration and the type of antibiotic would be given. Now, for example, supposing there is no epididymitis, then you may give the antibiotic for about 15 days. But if epididymitis is present, you need to give this antibiotic for at least 4 weeks. And if you feel that the seminal vesicles are affected on upper rectal examination, or there is prostatitis, you may have to give it from 6 months, 6 weeks to 3 months. So normally the antibiotics which penetrate this are the fluoroquinolones, and these could be any of the antibiotics like ofloxacin, levofloxacin, which need to be given in the full dose for a longer time. Azithromycin and doxycycline are also antibiotics which um, penetrate and cover the bacteria which normally would be causing the problem. Now, one thing for us to understand always is that the leukocytes are confused with round cells. So, a lot of times you may get a report where they may say 10 to 20 pus cells per high power field, and a test known as a peroxidase test has not been done. So, if a peroxidase test has not been done, then round cells or immature cells can be confused with leukocytes. And it's very important to be sure they're leukocytes or round cells because treatment would be dependent on that. So, an ENS test or a test which should normally be done, a peroxidase test, needs to be done on these seminal samples. Now, why should you look into leukocytospermia? You should look into leukocytospermia because it impairs motility, leads to poor DNA integrity, and morphology impairment. There is also DNA damage, and this DNA damage has been seen more whenever there is leukocytospermia. The treatment I have spoken about is antibiotics and antioxidants, and it becomes very important to treat these leukocytospermia infection because it decreases fertility not only because of DNA damage but also because of agglutination. And the head to head agglutination normally gives us an idea that there may be anti-sperm antibodies, but in case agglutination is present, the PCT is poor, leukocytospermia is present, and a culture shows bacteria, these patients definitely need to be treated for a reasonable amount of time. Now, I would like to just highlight and bring to you a few things which everybody should understand. That is, that FSH and LH driven testosterone plays a very critical role in providing the optical conditions for a healthy sperm. So we know that the Leydig cells in the testes are stimulated by LH to produce testosterone. And this testosterone is intratesticular. This testosterone is not extratesticular or the blood testicular testosterone. So the primary function of intratesticular testosterone is maturation of the round spermatids to mature sperms. And the primary function of FSH is to increase sperm quantity in synergy with cell proliferation. Spermatogenesis, of course, takes place about 74 days in humans. Now, what is critical in the males? In the males, it is critical that in case there is deficient endogenous gonadotropic production, gonadotropin production, it will lead to hypogonadotropic hypogonadism. And if there is intrinsic spermatogenesis impairment, which means primary testicular failure, as in non-obstructive azoospermia or idiopathic infertility, we need to be very cautious about having a good intratesticular testosterone. So let me bring out one thing for you to and everybody to understand. When you give testosterone as injectables and capsules to infertile people, like a lot of people give, a lot of quacks even give it, so the testosterone in the peripheral blood increases, but it does not become intratesticular. So what happens is it knocks off the LH and the FSH, and it in fact decreases the intratesticular, which in turn leads to even further oligospermia or azoospermia. So testosterone oral or injectable has no role in male infertility treatment. I hope this single message, if it goes to everybody, my job is done. Now let's come to hypogonadotropic hypogonadism. So in hypogonadotropic hypogonadism, it can be congenital or adult onset. So if it is congenital, we would normally give these people SCG 2,500 to 5,000 international units bi-weekly, along with HMG or recombinant bi-weekly for 6 to 12 months. And if it is adult onset, we would normally give these people HCG 1,500 to 5,000 again, alone for the first 3 months. And then in case we feel that the sperms have not come, we can add HMG or FSH 150 international units bi-weekly for another 3 to 6, 12 months. We need to monitor FSH-LH testosterone E2, examine the testes for their size, do an ultrasound, and we ultimately, the goal is that we should get sperms in the ejaculate and try for a natural IOI or ART pregnancy. So this is hypogonadotropic hypogonadism. So we treat them by gonadotropins, and the results are best in men who did not have undescended testes. So it's interesting and a beautiful disease to treat because the results are very good. So the Leydig cells are normally primed, I repeat it again, with HCG, 2000 to 5000 international units. And the serum testosterone should rise. And the serum testosterone should reach about 400 nanomoles. Sorry, uh, uh, once you have, it should increase to a level above 10 nanomoles in 4 to 6 weeks. But HCG may need it to be increased, and once it is, the testicular size has come to normal, then you add HMG or recombinant FSH twice a week to stimulate these Sertoli cells so that spermatogenesis may take place. Now, this is a very interesting patient. This was the first patient we treated about 14 years back. Hypogonadotropic hypogonadism, 16 years of, he came to know about it when he was 16 years of age, took no treatment, got married, came to us. We saw both the testes had a small volume. FSH was 0.4, LH was 0.5, facial pubic hair were low, testosterone was low. Started him on HCG. Testosterone became normal in 6 weeks. Testicular size became good. We started on HMG and sperms appeared at the end of the 14th week. Sperms were not very good in number. We did an ICSI. First cycle did not conceive. Second cycle had quadruplets because we didn't know, and we just want to give them a pregnancy, so we transferred 4, and we did a fetal reduction, and they gave birth to 2 healthy babies. Another patient, 34 years old, from the same city from where I am, hypogonadotropic hypogonadism, no sperms after 12 months of therapy, testicular biopsy was done, sperms harvested, ICSI done, and gave birth to these 2 beautiful babies. So in the last couple of years, I'm talking about the 9 patients we have closely followed up, though it's a very small number, but 9 patients who were diagnosed, 5 patients had sperms within 4 to 12 months. 1 conceived naturally. 4 underwent ICSI. 3 out of them conceived. See, please realize the woman is fertile and waiting for an embryo. So the results are extremely good. And 1 patient underwent testicular biopsy. Sperms were recovered. ICSI was done and pregnancy is achieved. 1 patient had no sperm development even after the biopsy 12 months after therapy. And 2 patients had no sperms after 4 to 5 months and were lost to follow up. Keeping this in mind, we realize that this is something which is treatable. And gonadotropins have a beautiful role in hypogonadotropic hypogonadism. So treatment, of course, is by gonadotropins. Few patients can conceive naturally. Sperm should be frozen the moment they appear. These sperms can be used for ICSI. In case the semen is negative, TISA is possible, and these patients can bear their own offsprings. So this is the conclusion which we have arrived to in the last couple of years for hypogonadotropic hypogonadism. A beautiful paper by Ramaswamy where he mentions he has a very large series. I mean, 3 people whose work has been phenomenal. One of them is, of course, Sandro, Dr. Ashok Agarwal, and Ramaswamy. And there is so much from their work which all of us have got. In fact, a few of these slides I have borrowed from them. So, in Klinefelter syndrome, if the testosterone is low, which it actually is, if you give these patients HCG and bring their testosterone level to normal and do a retrieval after that, the harvesting is much better than doing it right away in non-obstructive azoospermia. So the dictum goes that in non-obstructive azoospermia, if we're going ahead for a micro-TSA and the patient has a low testosterone, give him HCG, aromatase inhibitors, or anti-estrogen for at least 2 to 3 months, and you are going to get better results if the testosterone reaches above 400 or 300. And it's always better to do a biopsy or a micro-TSA once these hormones have been given to these patients. So in non-obstructive azoospermia, so I had spoken to you about gonadotropins to be given in hypogonadotropic hypogonadism. But in non-obstructive azoospermia, the mechanism is an increase in the intratesticular testosterone production. And it resets the FSH action. So what happens is that whenever the intratesticular testosterone is high, it promotes spermiogenesis, spermatogonial proliferation, and upregulation of androgen receptors. Now, FSH resets to normal levels once this happens, and the expression of FSH receptors becomes better. So, Sertoli cell function improves. So, in non-obstructive azoospermia, once again, you would like to give these patients HCG, and in the patients in which the FSH has come below 1.5 international units per liter, add HMG or FSH so that the testicular levels could be 500 to 800 nanograms per deciliter. Then go ahead for a micro-TSA or wait for a sperm in the ejaculate. So I've spoken to you about infections, medicines to be given for it. I've spoken to you about hypogonadotropic hypogonadism. I've spoken to you about non-obstructive azoospermia, when to give these patients gonadotropins and how to give them gonadotropins before a micro-TSA. And now I'm going to speak to you about the ejaculatory disorders. So an ejaculatory disorder, how would you suspect it? If there is a low volume and retrograde ejaculation is present, and whenever there is retrograde ejaculation, what happens is that there is an abnormal flow back into the bladder instead of the ejaculation. And when this happens, normally it could be no ejaculation at all in these men. So, some medications are there which can be given, and these medications are normally what I give these patients is imipramine, 25 milligrams twice a day. And you would like to give them about 7 to 10 days before the planned ejaculation. And if they are able to ejaculate during this time, great. Because after 2 weeks, if they do not ejaculate, you could understand that ejaculation will not take place. This only happens in those patients who have not had a surgically operated bladder neck. So now, if this therapy fails, you could either do an alkalization of the urine and collect these sperms, or go ahead for an ICSI with sperm retrieval. So, next, of course, all of us know is the excessive oxidative stress. Now, a lot of work has been done on this by Dr. Ashok Agarwal in the United States in Cleveland Clinic. And the sperm functional capacity, which means the sperm number which you get, gives you an idea that the number is fine, but the functional capacity of the sperms is different in different people because of the oxidative stress. So, in this slide, which I have borrowed from them, you would see over here that you would have the male accessory gland infection, prolonged stasis, immature sperms. They all together, along with drug smoking, pollution, diabetes, cancer, systemic infections, they all give oxidative stress to the sperm. Now, why do they give oxidative stress to the sperm? See, the sperm has a head which has tightly bound chromatin and very little cytoplasm. So, the sperm doesn't have a place where it can actually go ahead and hit much against the oxidative stress. There is no cytoplasm. So, this is the first place which gets hit, and it leads to spermatozoal dysfunction and infertility. Now, how can you measure oxidative stress? There are a lot of tests available for it now, and now, in fact, a few kits are available to find the oxidative stress. And once the oxidative stress has been measured, you would come to know if there is oxidation or not, because ultimately, this oxidation is going to give sperm DNA fragmentation. Now, if you have done sperm DNA fragmentation and you get abnormal results, you would like to identify the underlying condition which is causing sperm DNA fragmentation. You would like to avoid those promoting oxidative stress, like infections, like pollution, smoking, drugs. You would like to give these people oral antioxidant therapy. You would like to treat the underlying condition, which can be varicocele, for which you would like to do a varicocele repair, microscopic. And you would like to do the varicocele repair, treat the infections, and then, of course, you would like to give these patients, in case you find that the testosterone is down, hormonal therapy. A lot of these patients, if they have not got pregnant with this, need assisted reproductive technology, which is ICSI. And in case the sperm DNA fragmentation is very high, then we may need to take a testicular sperm, because a testicular sperm is not exposed in the epididymis or outside to oxidative stress. So the chances of DNA fragmentation are lowest in the testicular sperm. So we may have to do a testicular sperm and use a testicular sperm for ICSI to have the best results. Now, DNA damage, I have spoken about yesterday about the DNA fragmentation. Live births are less, Results of IUI are very low when DNA fragmentation is high. ICSI has better pregnancy rates because the maternal oocyte is able to repair the DNA of the male. And what are the antioxidants which normally are available? You have coenzyme Q, vitamin E, melatonin, arginine, zinc, selenium. Now, there have been a lot of major studies, and in fact, the Cochrane database shows us that antioxidants improve the live birth and pregnancy rate for subfertile couples undergoing ART cycles. Well, once again, once it has been diagnosed, you would go to the source: varicocele, genital infection, smoking, medication, drug abuse, systemic disease, pollution, radiation, testing for leukocytes in semen, and then there are a lot of antioxidants which can be given. A few antioxidants which are very important are vitamin E, vitamin C, zinc, selenium, folic acid, along with that, coenzyme Q, carnitine, astaxanthin. There are a lot of all of them available, and these need to be given to the men who have oxidation. So, of course, live births are better, pregnancy rates are better. The Cochrane database shows DNA fragmentation is less, miscarriages is less, and of course, adverse effects are very, very minimal of giving antioxidants. So, next we come to obesity related male infertility. So, you must have seen in your clinic, I get it right away now. If I'm sitting in my clinic and I have somebody who's very well built, who comes and enters the clinic, and the moment he enters, I would know that this man has had gym steroid abuse and he's going to have impotence. And this man is probably going to have oligospermia because of external testosterone and anabolic steroids. The intratesticular testosterone, which I had spoken to you about, goes down. Or if he's very obese, I would understand that his E2 level is going to be high, his testosterone would be low because the fat converts the testosterone into estrogen. So the estrogen will be higher, testosterone will be low, he would be oligospermic, and commensurate with his body, at times they have very small testes as well. These men also have erectile dysfunctions with genetic dysfunctions. So what happens is a man who is obese, he has a hormonal problem. A man who is obese, he has um, a genetic problem, can have a genetic problem, and these men who are obese also have intercourse difficulty in intercourse, sexual problems. They all together lead to a situation where the baby is not born. And sperm production per se, even otherwise, this was Human Reproduction 2005. The estimate was that the more the body mass index, the lower is the sperm count. So I've spoken to you about this, that obesity leads to all of this. Now, what would you do? You would look at it and see if the TE ratio is less than 10. So normally a TE ratio would be more than 10. And in case it is less than 10, then these patients need aromatase. There is aromatase hyperactivity. So they would require aromatase inhibitors. So anastrozole would be given. It is 1 milligram, not QID, OD, for about 60 days to 90 days, till there is a normalization of the TE ratio and sperm count improves. A lot of people use empiric. I wanted to talk about this. In oligozoospermia, a lot of empiric treatment is given. Some people give androgens, which is a big no, which I spoke about. HCG, HMG, FSH, aromatase inhibitors, anti-estrogens, bromocriptine, alpha blockers, systemic steroids. In general, they are not effective and they could have the side effects. Please do not give injectable testosterons. It would lead to marked fall in intratesticular levels and lead to azoospermia. Now, gonadotrophins I have spoken to you about, but in idiopathic, or I would say normo gonadotrophic men, it has actually in a lot of studies failed to demonstrate a beneficial effect. But a few people could be benefited where the testosterone is in the range of low normal. So anti-estrogens, well, everybody has a question to ask me about clomiphene. So clomiphene is normally prescribed as a 25 milligram daily dose. You would give chromosome who demonstrate an elevation of serum FSH, LHN, uh, testosterone levels. If they are lower, it may have an advantage. But if the FSH level is very high, then normally there is less of an effect of this clomiphene. So a lot of studies have been done, well-designed prospective studies have been done, and a lot of them have failed to identify any efficacy. But a few studies where they have found that 25 milligram of clomiphene daily over a placebo has a better pregnancy rate. And what we normally use them in is where the testosterone is low or it is around low normal. Then we add clomiphene to these men. Tamoxifen is another drug which has been used for a long time, but Cochrane database assesses 10 studies over a period of time, and only five trials specify randomized protocols. So in these studies even, it was found that the increase in testosterone probably was there, but it did not translate into a better pregnancy rate. Well, if there is hyperprolactinemia, then of course you would like to give these patients cabergoline. And once it has come down, because please understand, hyperprolactinemia affects the sexual and erectile function of the man. So, in case there is an erectile dysfunction, get a prolactin done, along with, of course, infertility, and bring the prolactin down by giving these patients cabergoline. Spoken about clomiphene, anastrozole, and idiopathic male infertility. Now, I'd like to speak about some future perspectives. So, now what has happened is that in the future, sperm biomarkers may be used as diagnostic and treatment tools. So, biomarkers basically are in the process which is going on, some metabolites which are formed in the cycle, if you could detect them and place them into an areas which could guide you of what treatment needs to be given, these would be specific biomarkers. There have been a lot of things now in the prospects of male fertility preservation. Stem cell as a new agent for treatment of male infertility. With genetic testing and current diagnostic tests, there is still a large proportion of idiopathic non-obstructive azoospermia and, of course, OAT cases, which are likely to be affected by some genetic factors. And these genetic factors need to be diagnosed so that in the future the treatment could be better. Now over here, this is a slide which I'd like to bring to you about that how it could be in the future and for storage of sperms. Now, supposing there is somebody who has cancer, a child. So if this child has developed sperms, you could store the sperms. Otherwise, the testicular tissue could be xenotransplanted into a mouse to get sperms. In the future, a lot of organ tissue culture has been done. Spermatogonial stem cell culture has been done in mice. They have actually created in the laboratory these sperms, micro-inseminated mice with these sperms, and have had baby mice. This till now has not been successfully done in the humans, but in the future it probably would be done. You could do an organ culture, or they could be auto-transplanted. Now, you could have spermatogonial stem cells which have been taken out of the testes. These spermatogonial stem cells are the stem cells which produce the spermatocytes. So you could culture them or you could transplant them to get sperms. And in the future, you never know if from a skin biopsy and pluripotent stem cells, sperms could be made and they could be used for these infertile people. So, spermatogonial stem cells, I just spoke to you about. So, there could be male germ cell transplantation, xenotransplantation, functional genomics and differential gene expression, in vitro generation of sperms, well, of mice has been done, of human beings probably would be done. So, this is what I was talking to you about, where they have cultured sperms from stem cells and obtained spermatids, resulted in healthy sperms, and had offsprings from these. Now, I'll just add also a little bit about CRISPR to you. I don't know if you have an idea. So, what does a virus do? What does this coronavirus do? This coronavirus, it actually goes into our DNA, replaces a segment, and changes that segment. So, similarly, in CRISPR, they have used the same technique as a sequence uh, to scissor off the bad gene at an area and replace it. So, in the future, if both the parents are diabetics or thalassemics, if this gene could be cut off from the embryo and replaced, you would have embryos which would be free from the disease initially. In fact, it's very interesting. I was one day talking to my son in the sixth standard, was very fond of coding, and he wanted to become Sundar Pichai. So one day in the evening, I was speaking to him, and I asked him when he was in sixth standard. I just asked him that uh, there has been one Steve Jobs and whom you admire, and there is one Elon Musk whom you admire. But do you realize that ultimately the future of the world will be into preventive medicine, genetic medicine, medicine which actually can be working on genes, like and prevent the diseases. Then the diseases once then prevention or treatment of the disease once it's happened. So in this pandemic, we realized that the most important thing for us is to prevent the coronavirus from actually affecting us. And of course, vaccines has been something which have been developed in around 1.5 years, which used to take about 24 years earlier. Of course, one of the reasons is that the coronavirus structure was known because of the previous coronaviruses. And number two, the technology which has developed in the mRNA and the gene sequencing. But we realized, so I was speaking to him. So in the last 2 or 3 years, he has understood, and now he wants to become a doctor, but he wants to become a scientist because this is what he thinks would be great for the future. And that's been great. But coming on to the CRISPR technology. So in CRISPR technology, you probably would have embryos which would have no diabetes, no thalassemia, but also another thing could be done in the future, designer babies. I don't have a wife like Katrina, somebody could say, but he could have a daughter like Katrina. I love cricket. I would like a son like the genetic makeup of Sachin Tendulkar. So the class and the school and the cricket team will have a genetically modified boy as Sachin Tendulkar. The future could be in that area, but I'm sure that ethically it will not be possible, as you must have read that with CRISPR technology there are a lot of ethic issues because of which a lot of these areas will not be entered. Otherwise, it would be a very unfair playing field for human beings. So, I was talking to you about CRISPR technology, and I'll also like to bring you into another area of thought. Today, gay marriages are allowed. So, normally, what happens is that a man gives a sperm, the woman gives an oocyte, and a baby is formed. But now, if two men want to have a child, now what happens is that they would take an oocyte donation, and in a surrogate, the baby would be there, and one of the two would toss a coin and say, I'm the father and I would give the sperm. But in the future, there may be a situation where one man is going to give the sperm, the other man will give a pluripotent stem cell, which would be cultured into an oocyte. And though that oocyte with the sperm would make an embryo which would be placed in a surrogate. And for two women, one would give an oocyte, the other would give a pluripotent stem cell to be converted into a sperm, and one of the women is going to keep the embryos. to actually have a baby. The future may be like that not far from now, maybe 10 or 20 years from now. But the most interesting thing in this whole story, which I thought, let me tell you, is that the two women will never be able to have a son. So I end my talk over here, and I just wanted to talk about the future perspectives and spermatogonial stem cells. I've talked to you about generation of mature functional cells from spermatogonial stem cells. A lot of issues are there for the differentiation of these cells and mechanisms. But given the rapid progress, I can tell you one thing for sure. The world is not far away from this revolution and these new findings, which, if used well, would be extremely beneficial to the human race. And thank you very much. But before that, key messages: empirical medical treatment for idiopathic oligozoospermia is not recommended. Infertile males with hypogonadotropic hypogonadism, testosterone less than 300, are candidates for treatment. HCG is the treatment of choice for adult onset hypogonadotropic hypogonadism. Aromatase inhibitors are helpful in overweight obese men with aromatase hyperactivity, with a TE ratio is less than 10, and oligozoospermia. HCG anti-estrogens are helpful to boost testosterone production and in terms sperm production in selected ART candidates. A minimum treatment duration of 8 weeks to 12 weeks is needed, with monitoring the testosterone regularly for dose titration. Asymptomatic leukocytospermia is mainly caused by urethritis. ROS production is increased with an increase in leukocyte numbers. Antibiotic therapy is suggested, but the effect on fertility is still unclear. Oxidative stress is an important thing and risk for male infertility, and antioxidant supplementation for subfertile men improve the chances of live births in couple undergoing ART. Well-designed studies are needed to determine the best candidates for oxidative stress antioxidant therapy and which formulation and dosage would yield better results. I would really like to thank you for being with us on this wonderful occasion today. Thank you so much.
Thank you so much, sir, for your talk and for summing up the session for us. With your permission, sir, can we move to the questions?
Yes, please.
Okay, sir. So the first question is with Dr. Upendra Kumar Oli. He's asking if FSH and LH is high and testosterone is normal in patient of non-obstructive azoospermia. What are the chances to get spermatozoa by medical treatment or by surgical methods?
So, in this patient who has a high FSH and LH and who has a normal testosterone, if the testosterone is above 400 nanomoles, in this condition, you would not like to give any kind of SCG to the patient. First thing. Now, normally, if there has been a very big study of non-obstructive, in fact, a couple of them, of non-obstructive azoospermia with varicocele. And in patients, if the varicocele has been repaired, a few of these patients of non-obstructive azoospermia have had sperms in the ejaculate. So if there is no varicocele, then the chances of having sperms in the ejaculate are very low, close to nil. So this is a good patient for a micro TCA.
Okay, sir. Next question by Dr. Richard Rastogi. Isolated asthenospermia with normal count. How do we proceed?
You'd like to examine the patient. You'd like to see if the patient has any infection, any epididymitis, if the patient has any orchitis. You'd like to see if the patient has any seminal vesiculitis. Now, one of the causes for an isolated asthenospermia could be gonadotoxins. You'd like to see if he's been exposed to any gonadotoxins. You'd like to examine and see if there is any, and you'd also like to see the semen if there's any leukocytospermia. If that is present, you'd like to treat. If there is a patient, you'll also examine if there is a varicocele. If there is a varicocele, if there is infertility, if the woman appears normal, There's a count acinospermia. You may need to do a microsurgical varicocelectomy for this patient. So this is how would you go ahead and treat this patient.
Sure, sir. The next question is with Dr. Viraj. How do you approach your treatment for male hypo-hypo?
It's very simple. Male hypo, if it is adult onset, you examine the patient, you note the size of the testes, you start these patients, you first of all counsel them. It's very important to counsel them. So you need to explain to the patient that this is the condition, and you would need to give hormones for over a period of 6 months to a year, maybe, though the sperms may appear after 4 months. And if you're ready to take this treatment, which is hormonal treatment, then please join in and we would continue. Because the patients, a lot of these patients do not realize that they need to be injected for such a long time, and these injections are expensive. So they probably, after the first month, may leave. So they should be counseled first that if you're ready for this treatment, we're going to take you on first. Second, you normally start with HCG. So you start HCG 2000 international units twice weekly. Depending on the weight, you may give even 300 international units twice weekly, 3000, sorry, international units twice weekly. And you would monitor the testosterone monthly. Now, when the testosterone comes to normal, then you decide that, well, the testosterone is normal. You may add this HMG to these patients or FSH to these patients. What you normally give is 75 to 150 international units twice a week. You monitor the sperm and you wait till you get um, sperms in the ejaculate. You may get good sperms to get a pregnancy in natural intercourse. You may do an IUI. But the moment you get sperms, remember one thing, please freeze these sperms. It's the simplest thing to do for these males. Freeze these sperms. And once the sperms are there, they could get naturally, they could be IUI, you would need an ICSI. But then, of course, once you get the sperm, you can give them their babies.
Next question, sir. If a patient has teratozoospermia in repeated semen samples, then what options can we give other than donor sperm?
First thing, teratozoospermia, it should be measured by Kruger's criteria repeatedly. If there is any gonadotroxin, it should be removed. If there is a varicocele, it should be operated. If there are any kind of infections, they need to be removed. The person needs to be given antioxidants. I'll give you an example of a patient. I had a patient who had severe teratozoospermia and necrospermia. So the patient came to us, we did a host test of this patient. And in the host test and vitality test, we found 100% sperms without any vitality. So once we got 100% sperms with zero vitality, we started him on antioxidants. And we gave him antioxidants for about 4 months. We also did a culture. The culture was negative, so we did not need to give any antibiotics. He had no varicocele, so there was no question of any kind of a surgery to be done. And after giving him antioxidants, we did again see the vitality, and we found a few sperms which were viable. So then we went ahead and did an ICSI of this after doing the HOS and doing the sperm flexibility test. So with teratozoospermia, you need first thing you need to understand is you need to see if there is any contributing factor. If there is a contributing factor, you need to treat this. You need to do a good semen analysis by Kruger's criteria. Only then you will label this person as teratozoospermia. There are very few patients who have good sperm counts, good motility, and severe teratozoospermia. And if there is such severe teratozoospermia, there have been today 3 major scientific studies which show us that teratozoospermia per se is not a major cause of infertility if the sperm count and progressive motility is fine. I hope I have been able to answer your question.
Thank you so much, sir. How many attempts of IUI are worth trying before resorting to IVF in normal male and female with unexplained infertility?
The most important aspect to guide you is the age of the woman. If the age of the lady is more than 35, then in any case, with gonadotropins, if you do an IUI, 3 probably would be the maximum. But for a younger age group lady who's forming eggs well, 3 to 6 cycles could be underwent with, of course, COH, gonadotropin treatment.
So one last question. What's the cutoff for semen analysis used for male factor subfertility while advising IUI?
I beg your pardon?
What's the cutoff semen analysis used for male factor subfertility while advising IUI?
For IUI, what you actually need is 1 million total motile count in the inseminate, which means if you're putting in 300 microliter, there should be at least 1 million sperms in this. There have been a lot of recommendations, but less than 5 million, there is no point of doing an IUI. I'm talking of a less than 5 million count, total sperm count. But if you come to the basic tracks, you would like to see the total progressively motile sperms in the IUI wash. So if the IUI wash in 300 microliters has less than 1 million total motile count, there is no point of doing an IUI.
Thank you so much, sir, for addressing the queries of our audience. You've already summed up your talk in with some key takeaways while ending the talk, but I would still request you to have some final words before we end the session today.
Males are very sensitive creatures. When they enter your infertility clinic, they either stay out, they don't want to come in, and they don't want to get a semen analysis done. And if the couple is accompanied by the mother-in-law, then the mother-in-law always says, "My son is fine. There is no problem with him." So it's a very different kind of a situation where the male, who is the contributor of 50% of infertility, um, is normally not treated, looked after. Most of the ART specialists are lady RT specialists, and the males are not examined. So there are 5 things which I'd like to say now as a conclusion. Number one, the male is a 50% contributor. The couple needs to be examined, needs to be counseled, and they should be coming together first. Number two, the males always need to be examined. Ultrasound is not a substitute for examination of the males. Number three, oligozoospermia, which is idiopathic in nature, can be treated, or the sperms can be made better so that the patient which may be needing an IVF may be treated with an IUI. Number four, 60% of azoospermic men can have their own children by sperm retrieval and ICSI. So these are the men which be should be given a choice. It should not happen that they should be always told, please go ahead for a donor sperm. And number five, after the advent of ICSI, the studies into andrology and male fertility have gone down. However, male sperm count is an indicator of male health. So it's very important to look into what is the cause and looking into the male health. Looking, taking, you need to take care of that. Males need to be looked into. And fertility, I would say, treatment is not of the woman alone. The man is an equal partner. So please take care of him. Your results would be better. Your pregnancies would be better. Your patients would improve. And of course, the couples would be happier.
Thank you so much, sir, for highlighting the importance in the medical management of male infertility. And as you rightly said, both contribute towards a healthy baby. So it's important that both aspects of infertility, male and female, are looked very carefully. So with this, sir, I really express my gratitude on behalf of Bharat Serums and Vaccines for taking out time and delivering this session for us. At the same time, I thank my audience for a very patient listening. With this, we come to an end of the episode 36 of ART Masterclass Season 1 with Dr. Sunil Jindal. Thank you so much.
Thank you very much. It's been a pleasure to have you as an audience, and it's been a pleasure to have you, Pratik, as a host.
Thank
Thank
you
you
so
so
much.
much.